Good morning, my name is Joana, I'm from Portugal, and I'm very pleased to share this case with you today. On Christmas Eve, On Christmas Eve, a 37-year-old woman with ulcerative colitis on prednisolone presented with a one-week history of fatigue, anorexia, fever, diarrhea, and pleuritic chest pain. On examination, she was febrile, tachycardic, and had diffuse abdominal tenderness. Initial blood tests showed profound leukopenia with neutropenia and a markedly elevated C-reactive protein. So a CT scan was ordered, revealing bilateral lung nodules and liver enlargement. And obviously, a microbiological workup was started, and rapidly returning positive for Clostridioides difficile and MRSA nasal colonization. At this point, we are facing febrile neutropenia with Clostridium infection and possibly an evolving MRSA pneumonia. Thus, large spectrum antimicrobials were started. But despite this, she worsened quickly, requiring high-flow nasal oxygen and soon after ICU transfer. Apart from initial positive results, all other microbiological tests came back negative. She worsened more, with developing pancytopenia, high ferritin and triglycerides, and serial CT scans showed rapidly evolving consolidations, involving almost 80% of both lungs, and a new large pleural effusion. Even so, despite extensive investigations, cultures, viral loads, TB-PCR from blood, pleural fluid, and bronchoalveolar lavage, no pathogen was found. The hypothesis of HLH was briefly considered, but at this time, bone marrow only showed a granulocytosis. The full workup for pancytopenia was otherwise unremarkable. The echocardiogram was also normal. At this time, the team threw everything and the kitchen sink at her, including G-CSF. Still, her condition declined, requiring ventilation, vasopressors, and showed no response to G-CSF. Desperation set in. Running out of options, IRDS was considered, and high-dose corticosteroids were started. It was a leap of faith, and it finally worked. 1 month after admission, all antimicrobials were stopped, and she was transferred to our medical ward. But she had persistent low-grade fever, so a follow-up CT scan was performed, revealing new lung cavitations and muscular abscesses, a clear sign that this story wasn't over. The question now was, what tied all of this together? We hoped the abscesses might hold the answers, so we drained them twice and obtained purulent polymorphonuclear-rich fluid. Yet, like every previous investigation, it was sterile. We searched for answers, and it came back with one explanation: aseptic abscess syndrome, meaning we had to believe in immunosuppression and have patience. Meanwhile, we investigated and excluded other hypotheses, like an IBD flare, an autoimmune or autoinflammatory disease, an immunodeficiency, you name it. But the results were, once again, normal. Over the following weeks, there was a slow but steady improvement, still slower than we had hoped. Eventually, she was discharged after 95 days, and later, adalimumab was introduced, consolidating the response. Recovery finally became visible, and she and we got a Christmas present 1 year later. Despite some unusual details, in hindsight, no alternative diagnosis made sense. Aseptic abscess syndrome is a rare inflammatory disease, more common in IBD, especially Crohn's, marked by systemic symptoms and elevated inflammatory markers, and above all, polymorphonuclear-rich, sterile, deep abscesses that do not respond to antibiotics but improve with corticosteroids. There is no formal diagnostic criteria or a clear consensus on treatments, although evidence supports using immunosuppressants, reducing the rate of relapse. Probably the biggest challenge is having the courage to stop all antibiotics and trust immunosuppression in a patient who looks as critically ill as ours. A final word to pancytopenia. We cannot exclude that she also had another rare disease, an HLH. Thank you.
Thank you very much. And now we go to...
Well, it's a rare disease, but among the 120 submitted cases, we had 3 of them with that particular one. So it may be worth remembering, especially if the panic hits.
Congratulations on this presentation. We have an immune system festival, so we shouldn't forget that autoinflammatory diseases or syndromes are mono or polygenic,
yes,
inborn errors of innate immunity, and autoimmune diseases, which the IBD belongs to, are the errors of adaptive immunity. So they cannot live from each other. And my question is, when to switch in our thinking about the patient, the auto-inflammatory to autoimmune on in reverse, regarding that antibiotics and antifungals are useless in auto-inflammatory diseases, and DMARDs, as you mentioned, are dangerous in certain situations in adaptive immunity disorders. When to switch?
I think it's seeing the evolution of the patient, especially in a case like this. At the start, it was almost obvious to everyone that it has to be an infection because she has fever, she has a neutropenia, so it was a febrile neutropenia. It has to be an infection. So we had to wait to see the evolution to start thinking maybe this is not an infection, it is something else. And at this point, we need to reverse and think maybe we need to stop immune system.
Sometimes it takes 11 weeks.
Yes.
Any other hands up?
Yes, hi, congratulations. Do you remember her final count of leukocytes, platelets?
It was normal. I can't remember the exact numbers, but it was all normal. She had no anemia, no leukopenia, no thrombocytopenia.
Luc Mouton, there was no hypogammaglobulinemia, no warts, nothing for primary immune deficiency?
No.
Because I don't understand the link between agranulocytosis and then aseptic abscess. And, in WHIM syndrome, you can find such an association.
Yes, the granulocytosis was a finding 2 weeks after admission, more or less. And after that, she recovered the counts, blood counts. So we don't have a full explanation to what happened.
Are there any clues in somebody's condition that make you think that this might be aseptic condition, abscesses, except non-response to antibiotics? Are there any clues one can have?
I didn't hear the...
Are there any clues in the patient's condition that makes you think that this might be aseptic abscesses, or is it just non-response to antibiotics?
It remains a diagnosis of exclusion, so we have to wait to see that there is no response to antimicrobials, antibiotics, antifungals, antivirals.
All right, thank you so much. We have to move on.